Good morning, ladies and gentlemen. So we are about to start today's proceedings, and I'm Dr. Asanka Ratnayaka, and this is Dr. Bashi Sabbu from India. So Professor Prasad Katulanda is going to give the first lecture. I'll hand over to Dr. Bashi.
Hello, good morning everyone. I am Dr. Bansi Sabu. Currently I am chair for International Diabetic Federation Southeast Asia, and I congratulate Sri Lanka College of Endocrinology because now they had become the part of our IDF, International Diabetic Federation. It's my great pleasure to be here and to chair the session of my very close friend Professor Prasad Katulanda, to whom I know since years. He is MBBS, MD, multiple fellowship. He is a professor in medicine, Faculty of Medicine, University of Colombo, Sri Lanka. He is an honorary consultant endocrinologist at University Medical Unit, National Hospital, Sri Lanka. The topic is lean type 2 diabetes. That's very important. That is it a separate entity? Are we dealing in Asian countries a lean diabetes? Is it a different than what we are dealing in type 2 diabetes in Western countries? So over to Prasad for his plenary talk. And once again, I congratulate all of you to be here at 8:30 right time, and for Sri Lanka Endocrinology is a part of International Diabetic Federation. Over to Prasad.
Thank you, Banshi, and also let me thank Mudita and the college for giving me this start in plenary. I don't need to tell you about the burden of diabetes. Every day, millions and millions of people are being diagnosed. We reported about 15 years ago to Sri Lanka to have 10% of diabetes, and 15 years later, now we report 23%. You can understand when a population has 1 in 5 adults having a disease, how significant the burden is. And even in the younger age groups, this is becoming a huge problem, and so it's unimaginable. So there's a broad classification of diabetes. You know about the type 1, the common garden type 2, then there are hybrid forms, and then there are other specific subtypes of diabetes, particularly based on the genes, the monogenic forms, and then diseases associated with the pancreas, and then certain endocrinopathy associated diabetes, drug induced, as well as certain infection related diabetes, as well as unclassifiable forms, which might be later classified into one of these other forms. And then we know about the hyperglycemic disorders associated with pregnancy and so on. Before 1990s, there was another form of diabetes called malnutrition related diabetes mellitus, or MRDM, was there in the WHO classification. This was subsequently omitted because people thought that it's not a distinct subtype and there's no way to diagnose with distinct phenotypes, biomarkers or genotypes, and people thought it might not be very useful. But recent work among South Asians, and particularly in the low middle income countries, have regained the interest and enthusiasm, and there are a lot of subgroups working on, which I think Banshi and myself are also part of, to see whether we need to reintroduce this and whether there is any usefulness. So, what is the definition of lean type 2? It can be slightly different based on where you are living. Usually the severe malnutrition related diabetes is when there's severe thinness where the BMI is less than 18.5. And then lower BMI related diabetes is diagnosed when in Asians when the BMI is less than 23, and in the Western Caucasians maybe when it is less than 25. You can see the countries where mostly the lean type diabetes is type 2 diabetes is affected, particularly the low middle income countries close to the equator. So what are the metabolic and phenotypic characteristics of the lean type 2 diabetes? As we know now, they should have an antibody, mainly GAD, and other insulin and autoantibodies should be negative. Low BMI, as per the definition. They are less prone to ketosis compared to type 1. They have insulin deficiency compared to classic type 2. They have higher insulin resistance again compared to type 2, and they usually a bit older in onset to typical type 1. But however, There's a huge controversy going. Some people think that this is a form of type 2 diabetes in one extreme, and then others think there is another form of antibody negative type 1 diabetes. Then there are also other overlapping entities like the fibrocalculous pancreatic diabetes, particularly was very common in certain underdeveloped areas in the South Asia, where there's severe malnutrition, and particularly there's calcification of the pancreas with lower beta cell function, and some people might have fat malabsorption and other typical features of pancreatitis, was sometimes attributed to cassava eating in low socioeconomic groups. And then there is this entity called protein deficient pancreatic diabetes, again due to severe maternal and childhood malnutrition. This particular study, which was done in Sweden, was one of the landmark studies which looked at different subtypes of diabetes based on the clustering of important factors. And this was done using some diabetes disease registries, a very large sample size. They classified according to several subtypes: severe autoimmune diabetes, severe insulin deficient diabetes, severe insulin resistant diabetes, moderate obesity associated diabetes, and moderate age related diabetes. You can see broadly the distribution of type 1 LADA and the type 2 among these different clusters. And as you see, particularly in the cluster 1, it's mostly type 1, and so on and so forth. So the other important thing to notice is that in these clusters, the other phenotypes are also different. Particularly in the cluster 1 and 2, they have a high A1C, and they have low BMI, they have a lower age of onset, and then they have lower HOMA-B, that is beta cell function is low, and also they have lower insulin resistance compared to the typical type 2 diabetes and other variants of type 2 diabetes. So a large study, they showed that even in a Sweden, Scandinavian country, type 1 diabetes is not that common. LADA is a bit commoner. LADA is latent autoimmune diabetes of adults, where there is antibodies like GAD, but they typically don't behave like the classic type 1 presenting initially with ketoacidosis, but most of them might need insulin later on. The secondary diabetes is about 1.2%, and then there was a significant percentage unclassifiable, and then type 2 was about 88%. And the other important the phenomenon they showed is that in this clustering, particularly the cumulative incidence for insulin therapy, time to insulin therapy, as well as sustained insulin therapy was higher in the cluster 1, that is severe autoimmune diabetes, as well as in the cluster 2, where there is severe insulin deficient diabetes compared to the other clusters. So this is the important finding. And also the other information they showed was that the SIDD was GADA negative, but otherwise behaves like the cluster 1, that is like the type 1, with the lower age of onset, low BMI, low insulin, as well as poor metabolic control. The cluster 3, the severe insulin resistant diabetes, was characterized by insulin resistance, which was measured by HOMA-IR and high BMI. Cluster 4, mild obesity-related diabetes, again a milder form of type 2, again had the typical features of the type 2. And then the mild age-related diabetes also was showing typical features of type 2. So what they ultimately concluded and also suggested that the cluster-based classification is a better method than traditional classification because the combined information more than glucose would give more information about the choice of treatment and would be a step towards more precise, clinically useful stratification and also precision medicine, like whether to use insulin-resistant targeted therapies or whether to use insulin secretory-based therapies or insulin. and also it might help us better classify patients to recruit them for randomized clinical trial. Now, based on this study, my friend Dr. Mohan and his team in South India replicated this study in again a large cohort of Indian patients. So they looked at the age of diagnosis, BMI, waist, glycation, hemoglobin, lipids, and also they looked at the C-peptide, but they were not able to do the antibodies. And then they identified actually 4 replicable clusters, and 2 of which was unique to the Asian Indian population, which I would show here. Now, the cluster 1 is the severe insulin deficient diabetes. Cluster 2, insulin resistant obesity related diabetes. Cluster 3 is a combination of the 1 and 2, which was not shown in the Swedish study. So again, more or less similar data, where the severe insulin deficient diabetes, the age of onset is lower, but not very low. You can see 42. They have low BMI compared to insulin resistant diabetes, and their HOMA B was quite low, and their HOMA IR also low, similar to the Swedish study. And then the other important thing they showed was that particularly this severe insulin resistance and deficient group, the combined group, had higher predisposition for complication. That is also important in terms of patient care. And based on these studies, our friends Dr. Nihal Thomas and his group did a lot of other important studies where they came up with phenotypic characteristics of low BMI related diabetes, the LD. And here you see again they have compared the undernutrition or low BMI related diabetes with type 1, type 2, and the ketosis prone diabetes, usually not seen commonly in Asians but common in black people. It was also called flatbush diabetes. Now, the important things to see is that the type 1 typically onset is younger, and then the particularly when you take type 2, very strong family history. Also along with that goes the other subtypes like the MODY, again it's a genetically determined subtype, and the undernutrition related diabetes have a very low BMI. They don't have ketonuria, but their beta cell function is low, and their insulin sensitivity is high, similar to type 1. And here in most of the diabetic subtypes, except for the typical type 2 and then the ketone prone diabetes, there is where there is both beta cell and peripheral tissue insulin resistance is incriminated. In all other subtypes, the main problem is the pancreatic beta cell. So then there are a lot of other theories. Now, people think that childhood malnutrition might have some role to play in low BMI related diabetes. But in most studies on type 2 diabetes in the cohorts, individuals with undernutrition associated diabetes who had a history of childhood malnutrition but followed up with rapid catch-up growth and weight gain was seen as a risk factor for type 2 diabetes. But some studies have shown, particularly in the very low socioeconomic groups, underdeveloped areas, that low birth weight and persistent malnutrition is also associated with diabetes, particularly type 2 diabetes. So again, Dr. Nihal Thomas and his group did a very elegant study including clamp studies. Clamp studies are the gold standard when you want to check insulin secretion and insulin resistance. Very complicated, very advanced studies. And they particularly looked at people with low BMI, BMI less than 19, but the patients were in very low socioeconomic groups. GAD antibodies were performed negative, and then insulin secretion assessed with C-peptide, and then the peripheral insulin sensitivity and the beta cell function was checked, as I said, with the clamp studies. And also they looked into the hepatic and myocellular lipid content with advanced MRI spectroscopy. You see here again similar data to what we have shown, particularly the low diabetes group. Anyway, these are low body weight groups. They had the low BMI, even lesser than the type 1, but compared to type 2, much lower. And then again, they have lower fasting insulin and also C-peptide, and they had better insulin sensitivity, and which the data similarly shows here. You see the normal people, they get very good insulin following OGTT or a meal, but you see the type 1s on the baseline here, no insulin secretion at all. The type 2, you see the first phase is not shear, it's blunted, and then this is the lean diabetes, which has again lower insulin secretion as well as the absence of the initial peak like the type 2. So it is something between the type 1 and type 2. But this is a very good study, well conducted, very comprehensive, looked at all factors which I have already alluded to, and then the cardinal physiologic feature they demonstrated is that the defect of insulin secretory capacity opposed to insulin resistance. And then the typical features of classic type 2, increased hepatic glucose output and decreased peripheral glucose uptake not demonstrated. So with that, they concluded that it might be unlikely to be a subtype of type 2 diabetes, but the other side is that this is a very small sample from poor rural communities. And based on that, they came up with this physiology which I have gone through. And then there are a lot of proposed pathogenetic mechanisms suggested about the chronic undernutrition, where it might lead to beta cell blunting, and also with low protein diet, beta cells might not develop. And then again, theories on epigenetic modification, like the DNA methylation and so on. Then also, there are some theories suggesting the malnutrition might also cause reduced levels of antioxidants. So the reduced antioxidants will increase the oxidative stress, and which might lead to beta cell dysfunction and beta cell failure as well as beta cell damage. And the certain environmental and dietary toxins, cassava, I told you, this is one of the things which was incriminated in the good old days. And all these might interact to cause undernutrition associated diabetes, particularly in the low socioeconomic groups. Then about 15 years ago, we also did some work on these areas, on particularly young onset diabetes, looking at phenotypes and biochemical markers like GAD antibodies. One of the largest studies, we looked at 1,000 people with onset less than 45 years. And then we did extensive comprehensive evaluation, GAD antibodies, insulin, C-peptide, genotyping, as well as phenotyping. And based on these data, again, similar to that Swedish study, 88% of this population, young onset diabetes, was type 2, typical type 2. Then GAD positive type 1 is not very high, 2.1, LADA 3.3. Then we also found a group of about 5% GAD negative type 1, similar to what is described by Dr. The Kerala, the South Indian group. And then here we, in our genotyping, we found about 1% having mitochondrial diabetes. So when you are doing these studies, very important that you need to look into all possible etiologies. This is the subject recruitment. I think this is, I have already alluded, the GAD positivity. And then here you see the data on the GAD positivity and the need for insulin. So if you have GAD antibodies, you are highly likely to be needing insulin. And then other phenotypic characteristics, which I will show with some of these diagrams. Here you see, based on these subtypes, this is the HOMA B, that is the beta cell function. As expected, type 1 almost 0, type 2 has good insulin secretion. DKA, again type 1 common, type 2 very less common, and then there's a reducing levels based on the etiology. Metabolic syndrome hardly seen in type 1 and quite high in the type 2 and intermediate in the other groups. Then these are some of the other characteristics that we found in this mitochondrial diabetes. You see, compared to non-carriers, although small, they have lower age of onset, very low BMI, very low waist circumference, very low metabolic syndrome percentage, and they need insulin therapy much more than the typical non-carrier type 2 people. So ladies and gentlemen, the diabetes is a huge spectrum. You have the multifactorial typical type 2 diabetes, which is still the commonest, and on the other extreme you have the type 2 antibody positive, and then you have in between the monogenic forms, specific forms, the LADA and the syndromic diabetes, and perhaps the lean diabetes also might come here. We have a lot of dilemmas with lean diabetes. So, particularly, does it deserve a distinct category? Some people ask, why? Is there a need for distinct category in the official classification? There's, however, as I showed from the Vello data, there is some data are emerging on its uniqueness, particularly on insulin beta cell dysfunction, as well as lack of insulin resistance and absence of autoantibodies. And then, but identification of definite diagnostic criteria can be challenging about biomarkers, genetic markers. So, other important thing is, as I showed from the the Chennai data, Mohan's data, the things are changing with the population being obese. So this is also we have to consider. And then again, is there malnutrition independently associated with metabolic abnormalities? And the other thing some people ask is it reversible after nutritional rehabilitation? And also, what are the implications in the life cycle course, particularly malnutrition in the mother, protein malnutrition in the mother, and then continuous malnutrition in the newborn and the childhood and so on. So, what are the therapeutic implications on the life cycle? If so, this can be very useful exercise. So, ladies and gentlemen, we need to have further studies with larger sample sizes, one of which we have already embarked on, Dr. Banshi, myself, and few others in these subgroups. Also, we need different socio-economic groups in the same ethnicities, because in the Chennai, as well as in the very rural, poor socio-economic areas in India, things are not the same. And then we might also be useful to explore the genetic basis of the lean diabetes. And also, we need to also think about what would be the optimal treatment, because otherwise making a diagnosis is not useful, not helpful if you are not going to make use of your therapeutic decisions. Whether the insulin is useful, insulin secretagogues are useful, what are the implications if you use other therapies like metformin and so on. And also, very important, I showed you some data on the higher predisposition to complication on some subtypes. So, are there any specific things that we can do for prevention of complications? So, with that, I would like to conclude on my talk on lean diabetes and would like to thank all of you for your patient listening.
Thank you, Prasad, for a wonderful talk. As it's a plenary session, so we will not having any questions, but Prasad is available if you want any question or anything you want to discuss. He's always there, and a wonderful talk which he has given. and recent data which he has talked about, type 5 diabetes, which had become World Health Organization also talked about it, IDF is talking about it, and the lean diabetes which was introduced by Dr. Nihal Thomas and his group, and we were also part of the subgroup discussion also. So with this, thank you, and we close the session.
Yeah. Thank you, Prasad.